Okay, so good morning, everyone. Welcome to Pediatric Neurology Grand Rounds. Today we have Dr. Sanders as the speaker. Dr. Sanders is Assistant Professor of Neurology and Developmental Pediatrics at the University of Colorado in Denver. Her career goal is to enhance the lives of patients with neurodevelopmental disabilities through the lifespan by utilizing her combined background of special education and medicine to improve access and quality of age-appropriate specialized healthcare. She completed the 6-year neurodevelopmental disabilities residency training at Boston Children's Hospital, which included 2 years of pediatric residency, followed by 4 years of training in adult and child neurology and adult and child NDD. During her training, she founded a clinic for adults with NDD in collaboration with adult neurologists at Beth Israel Deaconess Medical Center. In her current position in Colorado, she initiated an adult developmental disabilities clinic in collaboration with adult neurologists at the University of Colorado, where she provides consultative neurodevelopmental care in the adult hospital system. UC Health. Dr. Sanders also serves as the attending physician in the Developmental Pediatric Transition Clinic at Children's Hospital, Colorado. Dr. Sanders is dedicated to developing more opportunities for adult neurodevelopmental care through clinical model innovation, collaboration with colleagues across disciplines, and mentorship of trainees. Now I welcome Dr. Sanders to start.
Thank you so much. Can you guys hear me all right? All right, let me know if there's any issues from the Zoom. Thank you so much for having me. I'm really honored to be here and love being able to talk with both child neurologists and adult neurologists. So I hope to highlight why intellectual and developmental disabilities is important for all neurologists, no matter the age group. And we'll talk about health disparities also and definitions so that we're all on the same page and know what each other is talking about. Define a common developmental disability, autism spectrum disorder, and talk about the etiology and etiological workup of what you do when you see a patient with an intellectual or developmental disability. And then I want to give some good tips for ways that I've found helpful to incorporate people with IDD into your practice and talk about some resources you can use for after today is over. So hopefully this is clinically useful for you all, and feel free to ask questions, or if people on the Zoom want to unmute, ask questions because I want it to be useful for you. So one of the reasons we're talking about this is because during our mentor's lifetime, so all of us trainees are training from people who didn't have training with people with intellectual and developmental disabilities unless they were at a state institution, which were very few in every state. So this is an example of a very famous state institution here in New York, Willowbrook Developmental Center in Staten Island, which was brought to light in the 60s with some documentaries of the horrendous conditions. But this is where all people with developmental disabilities were taken care of. Even if they didn't live there, the way that our country paid for healthcare services was only paying for services at state institutions. And so now this could be a whole other hour-long talk about how care is paid for and divided and conquered, but now people are cared for in the communities. People can live independently with services that are paid for and supported by community and state agencies. And most importantly, healthcare can be provided for in community agencies and in academic institutions. And so we are all now seeing these patients that are rising into adulthood, but not necessarily prepared for it because our training programs were developed at the same time that state institutions were in place. And so people with developmental disabilities weren't considered when adult medical training programs were developed. And despite that, the prevalence is growing. So this is just an example of autism spectrum disorder, that the prevalence is now 1 in 36. Honestly, the graph is only published every 4 years. So the next one will come out in 2024. But the latest estimate is 1 in 54. So that's if you think about it, 1/4 percentage point. And if you think about diabetes, that's a way higher prevalence than autism spectrum disorder, which is pretty wild. And most adult clinicians would feel comfortable taking care of diabetes or asthma, things with just as high, if not higher, of a prevalence than autism spectrum disorder. So we need to be prepared because all of these patients are living into adulthood. But unfortunately, there's a lot of health disparities that we face. So women with intellectual and or developmental disabilities are less likely to have cervical cancer screenings. They're less likely to have ever visited a gynecologist. And they're less likely to visit the dentist regularly, get eye exams, even receive routine vaccines, let alone the COVID vaccine. There's a lot of disparities there. And we see that underlying in these conditions, there's higher rates of adverse health conditions to begin with. And then they have disparities in attention to these care needs, which is just a cascade of disparities in preventative services, and then ultimately disparities in preventative care lead to much poorer health outcomes. Okay. Thank you. So I want to make sure we are all on the same page with what do we call these things when we see in clinic. So what is intellectual disability? It's characterized by significant limitations in intellectual functioning and adaptive behavior. And adaptive behavior covers many different everyday skills and practical skills. And these disabilities have to originate before the age of 18. This is from the American Association on Intellectual and Developmental Disabilities, AAIDD. And so going into what does that mean? So what is a deficit in intellectual functioning? So most neuropsychiatric tests are graded on a bell curve, as you can see. And so the mean is 100 and the standard deviation is 15. So less than 2 standard deviations below the mean, meaning 70, is intellectual disability. And then that's graded mild, moderate, severe, profound, every different standard deviation below the mean. So you have to have deficits in intellectual functioning. And then you also have to have deficits in adaptive behavior skills. So these are conceptual skills like learning language, literacy, social skills, and they're graded based on what you would expect for someone's age. So diagnosing a 2-year-old with intellectual disability, you have to have deficits in adaptive behavior skills of what you would see in a 2-year-old or a 6-year-old or a 22-year-old or a 67-year-old. And so we've all had to adapt our adaptive behavior skills and social skills throughout the pandemic and different ways of grading each other. And that's what's expected of people in general. So when there's deficits, you can diagnose intellectual disability when you have deficits in both intellectual functioning and adaptive behavior. Also deficits in practical skills, work skills. And I highlight here that these are, you diagnose intellectual disability when there's adaptive behavior deficits without supports. But that doesn't mean that people with intellectual disability can't have meaningful work, can't be successful with managing money and healthcare and travel independently with support. So this is my best buddy, Christy. We've been in the Best Buddies program together for the last 16 years, and she has worked at a grocery store for the last 15 years. And there's a lot of people without intellectual disability that can't hold a job for that long. And the reason she can is because she has support with activities of daily living, work skills. And without that support, yes, she has deficits in adaptive behavior and she has intellectual disability, but she has the supports in place to live a full life and to have successful work skills with that support in place. Intellectual disability used to be called mental retardation, but that's no longer an accepted term medically or socially. And what's interesting is intellectual disability, as of March 2022, in the DSM-5, there was a recent text revision that changed it to be called intellectual and developmental disorder. So why am I using an outdated term, intellectual disability? It's because I want to be clinically relevant for you all, diagnosing, billing in your electronic medical system. None of that has changed from intellectual disability to intellectual developmental disorder, but we should be prepared for that to change. So right now you should know the definition intellectual disability, and the medical definition of intellectual developmental disorder is the exact same. They've just changed the name. And the reason is because the WHO changed their definition several years before. So the DSM has done a text revision to keep up with the WHO, but we're behind. And then the medical system is even more behind. So when you code and when you bill and when you refer to services, for now, still use the term intellectual disability, but know that it might catch up and change to intellectual developmental disorder soon. So what's the difference? Why not use the term developmental delay? So I work in both pediatric and adult healthcare systems. And I can't tell you the number of times that I see a note saying, we have a 62-year-old with developmental delay, or here presents a delayed 47-year-old. And it's not delay. We have to define the disorder. A developmental delay means a failure to meet expected milestones, and you don't know where that trajectory is going to go. But that trajectory is usually defined after age 5. And so we are only able to use the diagnosis developmental delay until age 5. And that's, for example, a speech delay or another delay in any specific developmental milestone, or a global developmental delay, which means a delay in meeting 2 or more domains of developmental milestones. But after age 5, it's really important to define the developmental disability so people can get the services they need and the medical treatment they need with having the right code, because unfortunately in our system, that's really important. So when you see a developmental delay or something like that written in the chart, try and define the developmental disability. Developmental disability is the big overall catchphrase of any disability in any developmental domains through the lifespan. And these can be cognitive, physical, or both. And so this is why we often use IDD, intellectual and or developmental disabilities, because all people with autism, all people with cerebral palsy have developmental disabilities where they benefit from specific supports from developmental services, but they don't all have intellectual disability. So an intellectual disability is a developmental disability, but not all developmental disabilities are necessarily intellectual disabilities. They all must appear before the age of 22 as per the definition, but really just in any developmental period. And some might be physical, such as cerebral palsy could be physical only or physical and intellectual, and many are combined, like Down syndrome has both intellectual and physical disabilities, but they are all developmental disabilities. So whatever you call it, the most important thing is to consider the person first and how they want to be referred to and how they want to be treated and what supports they need to live a full life. So knowing the terms intellectual disability, developmental disability, especially in adulthood, are important for getting people the services they need, because oftentimes service agencies need certain codes to give people services they need. You guys have any questions about the terminology before we move on? All right. So let's briefly define autism spectrum disorder. And this is just an overview. We could definitely, hopefully there are other grand rounds dedicated to autism, but just so that we are, since it's a big part of the population of developmental disabilities, there's 2 main criteria that individuals with autism spectrum disorder need to have challenges in order to meet the diagnostic criteria. So A is persistent deficits in social emotional reciprocity. So that's communication and social interaction skills across many contexts. Then the other bucket of criteria is restrictive and repetitive patterns of behavior or interests or activities. And these symptoms must be present in the early developmental period and cause clinically significant impairments. And they also can't be better explained by another disability. So many people, especially our age, there's a lot more awareness now of neurodiversity. Think, gosh, I don't like when people touch my feet, or, oh, I'm really interested in this certain game. I must have autism or autistic features. But autism, you really have to have overall deficits in functioning socially in the community, whereas just having certain traits of any one thing doesn't define you as autism. So that's important to know, but it's also important to recognize when people do have this generalized challenges in functioning in the community and meet the disorder criteria, we as neurologists have the power to diagnose it. There really isn't a lot of other people that diagnose autism, and pediatricians, internists, we all need to be ready to diagnose this developmental disorder so people can get the supports they need. So what happens? A 38-year-old man presents to your neurology clinic to establish care. And after a careful history, you determine that he has intellectual disability. What do you do next? Obviously, providing for all of their medical and neurologic needs, but we also have to ask why. So as neurologists, we're the ones that look at the imaging. We think about, why did this happen? Why does this person's brain work differently than what we would expect? And so etiologic workup often includes genetic testing. And there's many reasons to do genetic testing. These are some from a recent paper where you can anticipate complications of what happens by knowing the natural history. Rarely, but it happens. You can identify a treatable cause or develop a prevention program. It can facilitate research and intervention services and access to supports and community services. And also, of course, providing genetic counseling and long-term planning. And what's not on here, but from my experience, are a couple more things that I see a lot are combating parental or family guilt of people. Fatima and I were just talking about how I have a patient, several stories like this, where someone's in their 40s, and we do genetic testing, recently found someone had Phelan-McDermid syndrome, which is a genetic cause of autism spectrum disorder, another intellectual disability. And the family had thought all along, oh gosh, does he have this trouble speaking and communicating and functioning because I hit his head on a door when he was a baby or things like that. And they harbor a lot of guilt, or something I ate during pregnancy, or all of this other guilt. And so when you can say this is a genetic disorder, it would have happened no matter what, that really can help combat a lot of family guilt and help them move on and move forward, even if the family already has an adult child. And another thing, I think this is important, even more so in the current day, is the conspiracy theories. So a lot of people think, oh, I have this disorder, or my family has this disorder because we gave them vaccines or other things. And really telling them this is a genetic cause helps combat those conspiracy theories as well. So genetic testing is indicated in all individuals with intellectual disability and autism spectrum disorder. And if someone hasn't had it, or even if just been more than 5 years since they've had genetic testing, you should order it. And so most of the time, chromosomal microarray and Fragile X are covered by insurance. And I don't know the details here as much, but across the country, that seems to be the case with most insurance companies. In Colorado, we can have this for free with Medicare and Medicaid. And so I'm showing you this to freak you out that you'll get a report like this and have to interpret it, but you really don't. You will get a report that is in prose, and it will tell you what the genetic difference is, if any, and it will explain it. And most genetics labs have access to a genetic counselor also that can explain it. So gone are the days when you have to have a genetic counselor to order genetic testing. You really are able to send it to a lab who has genetic counselors on staff and provides explanation of what you see. You don't have to interpret dots and lines and patterns. And as of late, there have been more reviews and studies of cost effectiveness and also time efficiency also that shows that exome sequencing should be first line for all neurodevelopmental disorders. So this is what the literature says, but just like we talked about the literature and terminology, our medical systems haven't all caught up yet with being able to order this and cover this in our medical system. So that's why I want to show you both, but you should know what the literature says, that first line should be whole exome sequencing, because the diagnostic yield is 36%.
Okay. We're just making sure things are set up for you.
In this large study. And if you have a neurodevelopmental disorder and an associated medical condition, it goes up to 53%, whereas chromosomal microarray is
You know,
only
that's what person is within the old one. You just cut it down. Oh, really?
don't worry. And we'll go to the next one anyways. All good. Thank you. So in my personal practice, I'm seeing about a 50% yield when we go through trying to do exome sequencing first and then chromosomal microarray if we need copy number variants, because the adults that come, I don't know why I have such a higher yield, but that's something we're looking into. I think it's because if you've made it into my clinic in adulthood, you have more severe developmental disability plus other associated conditions that bring you to a neurologist. And so that's what gives us the 53+% in our clinic. So this is a review we put together a couple of years ago of recommendations of what you do when you see an adult with intellectual disability. So everyone should be getting a pregnancy history, a birth history, even when you see an adult, because we have to ask why. Why did this person develop differently? And is it just like headache, primary or secondary, thinking of the causes of intellectual disability? Also, genetic testing is indicated in almost everyone. And if you see metabolic features, metabolic testing is indicated. But whole exome sequencing covers all of that. So you don't have to do separate metabolic testing if you have access to exome sequencing. And this is an algorithm of thinking about primary intellectual disability versus secondary intellectual disability and a guide for the workup. And really thinking that MRI, just imaging in general, isn't always necessary without the features that would guide you to an MRI in any other patient. So just because someone has intellectual disability or autism doesn't mean you have to get imaging unless there's other features that would guide you to that, like micro or macrocephaly or difference in muscle tone, and considering EEG and workup for seizures just like you would in any other seizure patient, not different because they have an intellectual disability. some practical tips that I have found from my background in special education and also just clinical experience with people with disabilities. So first, start off, always introduce yourself to the patient. Even if you know they're not verbal or you know they can't hear, they can feel you in the room, and everyone can feel you in the room, identifying the patient and also the other people. Because someone that's there might be their brother, or it might be someone that met them 5 minutes ago, or it could be their husband or wife, and you don't know, and you really can't assume just because someone has different intelligence who they're related to in the room. But always continue speaking to the patient while being inclusive to the other support people in the room. And ask them about communication preferences. So if they're not speaking, you could ask if they could identify something on a picture or an iPad, or if there's other ways that they prefer to communicate. And it's also really helpful at the beginning to quickly ask about calming techniques. So if someone gets upset, what would be a helpful way to calm them down? And it could be that they like tearing up paper or drawing on something or standing and jumping. And just knowing that can help you prepare for a successful interaction. It takes 5 seconds to do. I had plenty of people, we're just giving them some paper towels to tear up, helped everyone get through the visit more calmly. It's also important to always allow the patient privacy and confidentiality when it's appropriate, and try to do some of the history and exam alone with the patient if you feel comfortable. So the social history also, I think I skipped that. Where does the patient live? Does anyone help them with their activities of daily living? And do they have a legal guardian? It's all important things to ask. I get a lot out of understanding someone's developmental level by just asking, what do you do during the day? And it's also really important to ask if there's any concerns for abuse. Ask about all of the routine stuff too, because just because someone has Down syndrome doesn't mean they don't smoke or have sex or other things. The more tips for the exam that I find really helpful. So first one is explain what you're going to do before you do it, but don't ask permission. So demonstrate what you're going to do, but don't say, is it okay if I do that? Because you don't want to ask a question that you don't want the answer to. And so the answer is often going to be no. Can I look in your eyes? No. So when you feel nervous, you always tend to want to ask permission for something, but try to go against that feeling of wanting to ask and just explain and demonstrate. And that's honestly more considerate to guide someone through what you're doing, even though it feels considerate to ask, but that can get you in a more combative situation. And then describe what you're doing while you're doing it. I'm going to touch your knee. I'm going to look in your eyes. I'm going to look in your mouth, and save the invasive parts for last. And you can ask a person or a person who knows them well, what's the part that would be most irritating to them, and save that for last. So here's some techniques that work for me. First one is doing first then. So if you're having trouble getting an exam, so one of my pet peeves is seeing a trainee or a fellow attending say, exam limited to patient cooperation. I think it's just really important to describe what you see and to get as much as you can out of an adult with intellectual disability, just like you would do for a child. You often wouldn't say limited due to patient cooperation for a 2-year-old because you're expecting that, and you can observe and describe what you see. And that's really important to do in an adult also. So I find first then works really well. You can say, first, we're going to examine your knees, and then we're going to measure your head. Okay, I can do that. I can see what's coming next. Or if they have something that they really like their iPad or their phone, you can say, first, I'm going to look at your feet, and then we're going to do your iPad. But first then is something that is really standard in special education literature of how to be successful with someone that might have challenging behavior. Another one is if you're having trouble getting them to see if they have range of motion or lift against gravity, you can say, all right, on the count of 3, we're going to raise our hands. Or on the count of 3, we're going to stand up. Ready? 1, 2, 3. And like maybe you just felt like standing up a little bit, because it's natural when someone says 1, 2, 3 to want to just go into what's happening. So that can be a really helpful thing to get someone to do what you want to do. And these are also helpful for people who have dementia or strokes or other challenges communicating or interacting, not just intellectual disability. You can also try and get an answer from someone by giving them 2 choices rather than an open-ended question. So you could say, do you want me to look in your eyes first or tap your knees first, and ask them to choose. And you can put those options on 2 hands too. So an example can be, do you want pizza or broccoli? And you don't have to have pictures of pizza and broccoli on your hands, but you can let them touch your hands. And by having a more physical interaction rather than verbal, that can help open up someone's communication with you and say, this is a back and forth interaction. I'm listening to you. We're going to be successful. I care about what you care about. And even if they don't talk, that's okay, because they can still tell you something and you get that communication. And it can help open them up to talking in the future by opening the line of communication with something more physical than verbal. It can open up their verbal communication later for you too. So I've found giving choices to be really helpful. So a couple of those take-home points. When you're working with people with intellectual and or developmental disabilities, there's going to be more paperwork. And it can be very frustrating and time consuming, but I try to look at the positive side where it can be really helpful, because patients in residential care, often especially in the care of state agencies, they require MD issued prescriptions for everything. This includes Advil, this includes sunscreen, but this also includes exercise or anything you tell them to do. So while it can be really frustrating to have to write everything down and every encounter have to sign these forms, you can use it to your advantage by saying, for your optimal brain health, you need to exercise a half hour a day. And I'm going to write that down. And that means that the state agency who's providing your care has to provide a way for you to do this and follow this. So while it's frustrating to have to write everything down, don't forget to write down the things you really want them to do, and then know that it has to be done if it's a doctor's order. Supported decision-making is a really important concept when we're working with people with intellectual and developmental disabilities. And so there's a gradient of the levels of support that someone can have legally. And it goes anywhere from healthcare proxy, which we should all have. That is identifying someone who would take care of your health-related matters if you are unable to speak for yourself. But goes all the way to guardianship, where just at baseline, you identify someone to speak for the patient, or the patient identifies someone to speak for them for all health-related or financial matters, no matter what time of day or no matter what state they're in. Just at baseline, they have someone making their decisions. And then in between is power of attorney. So power of attorney is identifying an individual to make decisions for someone for certain things. So there can be medical power of attorney or financial power of attorney. And that is more similar to healthcare proxy, where if you're not able to speak for yourself, so the individual who has a power of attorney still has agency to sign their own name, whereas guardianship, that individual no longer has agency to sign their own name, is how I think of it. So these are often things that scare neurologists or other providers for working with people with intellectual disability, because who am I allowed to talk to? Am I allowed to talk to the patient? Do I have to talk to their guardian? And so hopefully this helps give some understanding and less fear when you're dealing with the complicated scenarios of guardianship. So when you're working with a guardian, here's just some tips to make it successful. Always scan a copy of the guardianship order so that everyone's on the same page of who is the legal guardian. And know that the patient can still be interviewed alone. So just because they have a legal guardian doesn't mean they don't have their own concerns and privacy that should be respected. And they should still be asked about their preferences. You should also still respect their privacy unless they're a risk to themselves, and you have to tell the guardian. And the guardian always needs to be consulted before an invasive or sedated procedure, but they don't have to be consulted for minor things. So keeping that in mind. So moving on to some neurospecific things, which I think can be helpful to understand as people with intellectual and developmental disabilities age. How do we assess change? This is something I'm often asked as a neurologist who works with people with intellectual disability. How do you know if someone's different if you can't do a MoCA, or if their baseline MoCA is 19? How do you know if that's dementia or not? Things like that, or mini mental status exam, all of that. So I think the first thing to think about is if you hear hooves, you have to remember it's almost always a horse, not a zebra. So common things are common, even if someone has an intellectual disability. So don't forget to partner with primary care and check basic things that can happen in someone who's aging. So check their hearing, check their vision. If you hear that someone's declining or they're falling more, don't automatically think it's some neurodegenerative process. And maybe they just need a glasses adjustment, or maybe they need a hearing aid and they're just a little more confused, and you can fix that. And then you can see that they're actually on their normal aging trajectory. Also, don't forget to assess for pain or infections like a UTI, and also mental health changes. These are common in the general population to come up as people age. Same thing with people with intellectual and developmental disabilities, but they can look like decline because their functioning can just decrease, and you don't necessarily know why unless you look at these common things. We also know This is a recent review in the Annals of Neurology that adults with cerebral palsy require ongoing neurologic care and have more common neurologic complications than the general population that we have to keep in mind. They have twice the risk of stroke, 8 times the risk of myelopathy. Often they lose mobility. There's chronic fatigue, chronic pain. And we think of cerebral palsy, we know the definition is that it's a non-progressive insult to the developing brain. But that is the brain injury that's non-progressive. Their symptoms can be progressive, and it's really important to treat them and look out for them and know that they could happen. And just, yeah, I think oftentimes people say, oh, it's just the CP, but they can have stroke, they can have myelopathy. The Down syndrome and Alzheimer's. I think it's really important to review what age this happens because many neurologists know that the Alzheimer precursor protein is on chromosome 21, and that makes people with Down syndrome, so we think, more likely to have Alzheimer's. We honestly don't know why still. The amyloid hypothesis is still up in the air, as that is a whole other grand rounds or two. But we do know the prevalence and we know the epidemiology of people with Down syndrome getting Alzheimer's as they age. Oh, it's coming. Okay, great. So what you should know is if you see a 20-year-old or 30-year-old or even 40-year-old going into 50s with Down syndrome and you hear decline, you have to think of those other things. Just like anyone with or without intellectual disability, you have to think of things that are common of why are they declining. And in their 50s and 60s is when people with Down syndrome do often develop dementia, Alzheimer's type, but it's not 100% of them. So you have to work up other things. This is the graph of the percent of dementia in people with Down syndrome. So yes, it is early onset Alzheimer's because 60s is early onset Alzheimer's, especially 50s is early onset dementia as we think of dementia. But it's 50s and 60s. It's not as early as 30s and 40s in most people. So once someone with Down syndrome develops Alzheimer's, on average, they live 4 to 10 years from the first symptoms, and the median is age 7. And it is important to talk to family members about that so that they can plan, because most people with a young family member in their 50s or 60s aren't necessarily thinking that timeline. And there can be rapid decline of dementia in people with Down syndrome. Co-occurring sensory impairments are extraordinarily common. And so fixing someone's vision or hearing impairment can really help them cope with their dementia. Seizures are also really common in Down syndrome and dementia. And the epilepsy diagnosis on average happens at age 55, about half a year after the average diagnosis of dementia. And so treating seizures, treating these other co-occurring sensory impairments can help someone cope and feel better and help the family cope with it by not seeing constant seizures all of the time, and helping someone hear and see better can make them less agitated as well. So how do you diagnose dementia? How do you know someone has dementia if they have baseline intellectual disability? Well, there are some validated screening tools now that are new, even since I've been in training. One of them is published by the National Task Group, NTG, which is the National Task Group on Dementia and Intellectual Disability Task Force. And so this is called the EDSD, the Early Detection and Screen for Dementia. And it's available in many languages. And this is an example of one of the 4 pages. So it gives you the options to say something has always been the case, it's always but it's worse, or it's new in the last year, or it doesn't apply. Rather than saying someone needs help with this, you have to know when they have a baseline of needing help with that, or this is new, or this is worse. So that's how the EDSD, early detection screening in dementia in people with intellectual disabilities works, is really helping you get that story of what's worse or what's always been the case. Keep in mind, preventative strategies are the same in Down syndrome and intellectual disability as they are in anyone else. And there are resources for this population to help with promoting healthy lifestyles, decreasing vascular burden, and also in general, increasing brain reserve, which we know in general dementia patients, keeping social interactions, employment, exercise, all of those are really important for increasing brain reserve and helping with dementia prevention, or at least prolonging the onset. So while we have some validated scales now, and I didn't put up there because it's not validated yet, but there's research ongoing for a mini mental status exam for people with Down syndrome that's more play-based, using blocks and toys and things for assessing their memory. So while there's some in progress and there's some that are validated, we have a lot of work to do for getting validated scales. And at this time, the most important thing is getting someone's story, really understanding who they were before, because people with Down syndrome and intellectual disabilities in general have such a wide variable presentation of their abilities, especially the adaptive behavior skills like we talked about. So here you see people that need help with functioning, people that maybe have mobility impairment, communication impairment, but really getting their story of this gentleman used to hike and climb mountains all the time. She was a competitive dancer. He was a competitive Special Olympics weightlifter and gave speeches. And getting to know their story of who they were before helps you understand who you're seeing now and the change that's happened and the support they need to get through that, whether it's a diagnosis of dementia, epilepsy, anything that's caused them to change. So to spend the last minute going through some resources. So here are some person and family-centered resources that are free, available as printable PDFs and are really helpful. And I will send the slides so you can have these resources as well. But these are books for families on aging and Down syndrome, Alzheimer's disease and Down syndrome. And I give this one on Alzheimer's disease and Down syndrome to any family who has a loved one with intellectual disability and Alzheimer's or dementia, not just specific to Down syndrome, for tips on caring for that individual. And then these resources I think are really helpful. So if you take away one thing from today, take away iddtoolkit.org. So this is really helpful for adult and child neurologists alike, because it's all been a long time since we've had medical school and remember all of the different syndromes and what comorbidities come with them. So there's these handy health watch tables. For example, Williams syndrome. You're like, oh, I know there's something with the aorta there, but I don't remember. Do I need to get an echo if they had a stroke? Things like that. These are really helpful tables of what to look for in different genetic syndromes, or not even genetic syndromes, but just developmental disabilities. Transition.org can be really helpful for understanding the process of transitioning from pediatric to adult healthcare. And then these are specific to Colorado, but there are also other really helpful New York community center boards as well that are agencies that support people with developmental disabilities. And then finally, treatableid.org is a really interesting interactive tool that is free and also helpful for that. Gosh, I saw that in medical school, but it's been 15 years, even if it's been 15 hours, we all forget and need reminders. And this, I think, can just help you feel more comfortable when you see someone in your clinic that has a metabolic disorder or another potentially treatable version of intellectual disability, to review why that happened, where it is, and what the treatment can be. Also, you can type in, it works both ways. So you can type in, for example, homocystinuria and get a review of where the deficits are metabolically. But you can also type in symptoms and it can help you diagnose a metabolic disorder, which is very cool. So this is like old-fashioned AI. I think that really soon we'll have much more, but this has been around for a while and is pretty helpful for reviewing metabolic disorders and just making you feel less intimidated when you get results of a genetic test that comes back, helping make sense of it. Well, thank you so much for having me. Feel free to email me anytime if you ever have ideas or questions, because we are in this together and there's really not that many people out there that care for this population, but we all should care for this population, and they're coming to adult neurology every day. So this is my daughter also, Rebecca, and I really appreciate you guys having me, my first moment back from maternity leave. So thank you. Yes. Thank you. Yes.
So, and that's one of our, we made that as a standard of care, which is really, it's like making a standard of care, it can't be done and then fail.
Yeah.
Which is what we did about 5 or 6 years ago. I think these things are very important. No one's really thought about them.
Mm-hmm.
And I also love the concept of what everybody writes for difficult to examine, not cooperative. I mean, it's just that was really great.
Thank you. Yes, I think it's really important we as child neurologists work with adult neurologists to help them feel more comfortable. And I don't have the answer yet, but that's my goal, is to find the answer of how do we make adult clinicians, no matter the specialty, more comfortable. And one of the ways I found makes them more comfortable is having us on call to just ask questions of. So I try and give talks to adult neurology. I give talks to surgery residents, internal medicine, family medicine. And then I say, email me, message me through the electronic medical record anytime you want. And they do. They say, oh, I remember you said delay versus intellectual disability. Can you remind me, or can you send me those autism criteria again? So I think the more we can get out there and be available to our adult colleagues, make them feel a little bit less intimidated of what do I do with this person that I never trained with, will be important. And I think including them in our training is the most important thing, because they weren't there when the training programs were developed, which is really too bad. Yes. Yes. So about 5 years ago, we petitioned the American Academy of Neurology to create a section on adults with intellectual disability. Yes. Thank you. Thank you. That's great. Yeah.
How do we get authorization for? Yes, because that's our biggest, roadblock.
Yeah.
And we will use ChatGPT.
Really good question. I have not used ChatGPT yet, but I think that's coming. I think that would be wonderful to not have to write requests for authorizations, but. Fabulous. That's really fabulous. I think along with getting our cause into the AAN has taken a lot of time and advocacy. Similarly with genetics. So one of the section meetings we have coming up, it's going to be Tuesday morning at 8 a.m., I believe, is the our section meeting for the adults with intellectual and developmental disabilities section, combined with the genetics section on how do we move forward genetic testing. And we had it last year also. We even invited pharmaceutical companies, anyone who could possibly come, please come, help us move this forward with. And we've also invited the policy people through the AAN also to be there to help us say how we need exome sequencing nationwide. It's so different state to state how we get it. How do we get this as a more national provision of healthcare? So working on that, but it's not there yet. But I can say in Colorado, we have pushed a lot and we are able to get exome sequencing when it's indicated with Medicare and sometimes Medicaid. So that's pretty exciting. I think, did I miss another one of your questions that I forgot to answer? I think that's, oh, the imaging, thank you. So with the prevalence of autism being so high, we're moving towards not imaging everyone with a developmental disability, because autism is a developmental disability and usually you find nothing. So whereas in genetic testing, we find something in, from my experience, it's 10 to 30% of autism without intellectual disability. So it's not everyone, but it's a lot more hits than you can find from imaging. So I haven't pushed for the authorizations for imaging unless there's another clinical sign. So if there's any movement disorders, tone abnormalities, seizures, anything else, then yes, to get imaging. But if it's just autism or even just intellectual disability, I don't routinely get imaging because of that effort of authorization and the low yield and low amount of help that it gives us in terms of changing the outcomes or guiding management. I think that's a difference now that we have genetic testing so available, whereas imaging used to be the main thing we were able to get. And now that we can get genetics, it can give us more information sometimes than imaging can without the hard signs on exam. But I think the advocacy and the passion, I think, is what will get us into adult neurology programs and the AAN. So we've spent more than 5 years pushing our way into the AAN. So first, we created the section on adults with intellectual disability. And then every year since then have requested it to be part of the educational program of the meeting. And every year have been declined, denied. We've flooded them with applications. And this year, finally, we've turned the tables. It's taken a lot of advocacy and work and pushing and getting ourselves on committees, things like that. So this year, we are in the cultural competency talk. So I will be leading a panel with people with Down syndrome and comorbid neurologic conditions to talk about how we interact with people with intellectual disability, because that's the angle we could get into the program this year, was in the cultural competency angle. And finally next year, really exciting, after more than 6 years of pushing and trying and tons of meetings, we now have a session on adults with intellectual disability. So stay tuned, come in 2024 to AAN. And I'm really excited because it's been a long time coming. Honestly, at this rate, I thought it was going to take my whole career to get one course into the AAN. So the fact it's now just been 6 years is very exciting. But keep requesting it, and they'll hear from their members that it's wanted, and then we will get even more. Yes, exactly. Yes. I will let you all know when the date and time is and what room in 2024. Please come and send all your friends. We'll make it worth your while. If you have any other questions or things you would want in a course, let me know also. Thank you. Yeah. Oh my goodness. Oh my goodness. Yes. Yeah, the first year that we had a. Yes. Mm-hmm. Great. Mm-hmm. Yes. Yes. There is interest, which is really exciting. The first year, so every year we've had a section meeting. And the very first year we had a section meeting, we were over capacity of the room. People came and said, and it was just a meeting about the section. It wasn't a talk. It wasn't an educational program. And all these people came saying, I want to learn how to deal with these patients that are coming to me and I don't know what to do. So that was really exciting that people came from all over, adult neurologists wanting to learn what to do, which has made us now change the section meeting each year into an educational session, even though it's not supposed to be, because people are showing up, which is exciting. Demand. Yes. I think it's really hard to say what therapy is going to be a breakthrough, because I think we still don't know what is autism. And I'm the first to say that I don't know what autism is, even though I see it and diagnose it and treat it every day. You see one person with autism, you see one person with autism. So I think that having the genetic testing will give us more natural history understanding of different trajectories of genetic causes of autism that can then guide us to treatments. But I think the behavioral phenotype, just saying a stem cell transplant when we don't even know what's causing it, I think is far away. So yeah. Asks. Mm-hmm. Yep. Right. Mm-hmm. Mm-hmm. Yes. It is really sad how the vulnerabilities. Mm-hmm. Mm-hmm. Yeah. Mm-hmm. Yeah. And as a new parent, I can definitely relate to how you would be so willing to do literally anything that could help your child in any way. And so it makes parents really vulnerable, no matter what the age of their child is, to do something that they hear could possibly help. And what I explain to families is we don't know that it can't harm them. So our job as doctors is to do things that are safe and that we know can help their child and that we know cannot harm them. And so I explain the benefits of therapies that are research-based, like ABA. And there are even antioxidants that are research-based, like N-acetylcysteine, NAC, like that has good randomized controlled trial behind it. It's not specifically FDA approved for autism, but it's shown to improve irritability. So when you sense that they want more natural treatments, you can guide them to things that aren't necessarily hard medicines, but that can help behaviors or target things that do have research to at least show they're safe and not harmful. Even if it's not, fully effective for every single person with autism. Yes, right. Sure. Yes, absolutely. Creating memories and having social inclusion and opportunities is huge. And we know there is research, like you can make anything, you can say there's research behind it because there's research behind inclusion. And so anything we can do to help someone succeed in an inclusive experience, whether it's swimming with dolphins or going to first grade or singing in a choir, acting, biking, there's so many different things that we know can help with someone's social experience that is research-based. And I think highlighting ABA, applied behavior analysis, and how that has a lot of research behind it and how it can be adaptive to match with the values of their family, I think is really important too, because people have some negative connotations surrounding ABA, applied behavior analysis, and explaining how it's research-based and how it can mix with someone's values or cultural beliefs and mold to that, I think is important to explain too. Awesome. Yeah. Awesome. That's awesome. Yeah, it makes a huge difference. It's a cousin to Special Olympics, both literally and figuratively. It's the founders are brothers. And so it's similar, but it's not so organized like every Tuesday is practice. It really molds to the social lifestyle of adults and helps you just be able to volunteer and make a huge difference without committing to once a week. So it's a really awesome program. Highly recommend, and gives you a lot of insight too into someone's life and their family life and the supports they have and the supports that are available. So you know what to offer your patients. So I would say literally way more than half of what I do in a clinic visit or what I offer is because of what I learned firsthand through Best Buddies and other things with families compared to what you can learn in medical school and residency. Oh, thank you. Other than ABA, any other treatments or that I suggest for ASD? So right now, so ABA is the only evidence-based treatment for the symptoms of autism spectrum disorder. So that A criteria of social emotional reciprocity and the B criteria of restricted interest and repetitive behaviors. But we know that autism comes with a lot of comorbidities like anxiety, like irritability, aggressive behavior, so many other comorbidities, but those being major ones. And so there are treatments that are FDA approved for irritability associated with autism. And this can just, I should put this in here because this is on my boards for child neurology, that risperidone and aripiprazole are the only FDA approved medications that have autism in the FDA approval, that have the word autism. And they are FDA approved and really effective for irritability associated with autism. And then other not FDA approved, but randomized controlled trials that I use, randomized controlled trial backed up drug that I use is N-acetylcysteine, that has shown and is pretty effective, maybe half of the time from my experience, in adjunct to risperidone or aripiprazole when someone has really challenging irritability, self-injurious behavior, other aggressive behaviors. So those are our main ones that I use. I think SSRIs can be really helpful for some of those repeating thoughts and some of those repetitive tendencies. If you notice that someone has an anxiety feel to the autism or to the challenging behavior, but think that some of the treatments really are for the comorbidities, and you use that, FDA approval for ASD for anxiety or for OCD to help with those tendencies that people have with autism. But specific to the autism, ABA is the only one. For now, there's a lot more research going on. There are a lot of people ask about marijuana, and there are a lot of studies going on about CBD. I'm in Colorado, it's very popular. And so we have randomized controlled trial happening now, the Cascade trial, but we don't have the results of that yet. So I always tell families, I can't say that it's safe and effective yet because my job is to tell you things I know based on research and safety and efficacy. Can I see it on here? Oh, thank you. I'm sorry. So are there any clinical benefits from genetic testing to an individual with autism being tested to the individual, or is it just for the broader academic research, broader knowledge? If there's no immediate clinical benefit, how do you consent an adult with autism? Really great question. So I think that there are a lot of benefits to the individual and to the family. And even if there isn't an individual benefit, even if we don't find something treatable or something that changes management, I really feel that the family knowing and having closure of that diagnostic odyssey of why their child is struggling can be really helpful for their care moving forward. And it can be really helpful for family planning, and it can be really helpful for them getting other medical treatment, because families might think they got an antibiotic for this ear infection when they were 2, and then they stopped talking, and then they developed autism, or they got this vaccine. And so they might be against traditional preventative medical treatment that is really beneficial for the person with autism throughout their life. And so to have that family re-engage with the medical system once they know that it wasn't this medical intervention or that medical intervention that caused autism, but that it was a genetic disorder all along, I find is really helpful for the individual's treatment and overall access to care. So no, most of the time we don't find a treatable cause for the autism. Sometimes there is a metabolic disorder, or they're like Phelan-McDermid syndrome, for example. That was really helpful to find because there are lots of studies ongoing for Phelan-McDermid syndrome. They develop this agitated catatonia in their teens and early adulthood, which is really challenging. And so that's why this adult patient came to me with autism in his 40s, all of a sudden very agitated, and in Phelan-McDermid syndrome. And so then I can go to that literature and see that there are certain medications that work better than others in that genetic disorder. So it might not be a treatment of the genetic disorder, but it helps you by having a community of knowing what has helped with other people with that genetic disorder. And I think that that body of research is only going to balloon very soon, as now this population of people who have genetic etiologies known of their autism or intellectual disability becomes adults, we understand more about their medical and natural history, and can then test interventions, whether it's behavioral or medication or potentially stem cell transplant in the future and things like that, or genetic treatment. So those are my experiences of how it can be helpful to the individual. And I wouldn't do it if I thought it was just of academic interest. I really think there's more that people can immediately benefit from. And that's going to be the whole talk this year of the section meeting. So I believe it's Tuesday at 8 a.m. at AAN in Boston. And it'll be available virtually, I think, too. That's the big, we're having a informaticist come to that too, to talk about how AI can be helpful with ordering genetic tests, deciding what to order. We're having a big panel about, are we being too broad? Because we have these recommendations for exome sequencing, but is that too costly? Should we utilize AI to actually narrow down what we order? So it's going to be a very interesting conversation. Yeah, thank you so much for having me. Thank you. Thank you.